Welcome to the American Academy of Sleep Medicine Presidential Town Hall Forum with Academy President Dr. Kannan Ramar. Today's discussion is a COVID-19 and sleep medicine update. I'm Thomas Heffron, the Academy's Senior Director of Marketing and Communications, and I thank you for joining us today for this live webinar. Joining Dr. Ramar for this forum are two panelists, past President Dr. Doug Kirsch, who now chairs the Telemedicine Presidential Committee, and Dr. Indira Gurubagavatula, Chair of the Academy's COVID-19 Task Force. This forum will include time for live questions and answers, so I encourage you to use the Q&A button to submit your questions in the webinar platform. We'll respond to as many questions as time allows. This webinar is being recorded and will be made available as a free resource on the Academy website at aasm.org. Now, it's my pleasure to introduce Academy President Dr. Kannan Ramar. He is a sleep medicine physician at the Center for Sleep Medicine and a professor of medicine in the Division of Pulmonary and Critical Care Medicine at the Mayo Clinic in Rochester, Minnesota. Welcome, Dr. Ramar.
Wonderful, and thank you very much, Thomas, and good morning and good afternoon to everyone. I really appreciate you taking the time to be here with us today for this particular webinar. So with that, I'll start off with the first slide out here in terms of what AASM has been doing in terms of response to COVID-19. And as Thomas pointed out, we have two panelists here who are actually chairing the task force on COVID-19, as well as the new Telemedicine Presidential Committee that was started last year to benefit our members and to help get things moving related to that. We also have been putting out summary of CDC recommendations as relevant for sleep medicine practice, including multiple FAQs for sleep clinicians. And there's a website link related to that, that if you're interested, you might be able to access that as well too. So we have a collection of COVID-19 articles on JCSM. Thanks to Dr. Nancy Collop, who's the editor-in-chief for JCSM, for putting this all together. And so this will be a wonderful resource for folks who want to look at using this for their own practice. Similarly, we have a webinar on health policy and legislation that you might be able to tap in anytime, along with free lecture and telemedicine videos and series related to COVID-19 and other issues that you might encounter as well in your daily practice. We've also created a flexibility for accreditation, and this includes virtual visits. And in fact, getting feedback from both our virtual site visitors as well as from the sites, it's been very positive in terms of how things have been going overall in general related to this. And if you look at the other things that the AASM has done, this includes waived facility membership dues in 2021, and this includes for the AASM accredited sleep facilities. We also, thanks to the Academy and the board, we are offering a free subscription to AASM Sleep TM Select, along with discount minutes for individual and facility members. And we also are offering free member registration for the sleep medicine disruptor course, and this was based on input that we received from our members through our previous COVID-19 Pulse survey in terms of wanting free educational courses. And so this is something that I would encourage you all to attend on March 12th, between March 12th and 13th, 2021. In fact, there's also more lobbying and new public awareness campaigns that's going to be happening in 2021. So more to come on that, and hopefully you'll hear more of that in the Insider and through other means as well too. The COVID-19 Relief Fund for state and regional sleep societies is something that an initiative that the board and the Academy took with each state's getting about anywhere between 7,000 to 10,000 if they had applied for relief, and this is hoping that it's going to help you and the state's societies to benefit from this. The last one of the other items that I wanted to quickly touch upon is the foundation aspect in terms of the relief funds that have been awarded to our current foundation award recipients to take care of their financial heartstrings here.
Well, Dr. Kirsch and Dr. Gurubagavatula, while Dr. Ramar is getting his computer back up, maybe we can go ahead and kind of have some initial discussion here. Dr. Kirsch, I'd like to start with you. I know during your term as Academy President, without knowing it, you actually kind of started prepping us for this past year, talking a lot about disruption, and COVID turned out to be the ultimate disruptor, I think, right? So I'm curious kind of what your general thoughts and impressions and learnings have been during this past year as you've seen COVID disrupt, your own personal practice and the facilities you help oversee.
Thanks, Thomas. Obviously, I don't think that I predicted a viral pandemic during my presidency, but I will say it's not shocking in the world of medical practice that things happen, things change, things evolve, and sometimes they have to happen faster than at other times. And I think COVID and the pandemic that has occurred has really pushed people in a number of ways that they hadn't necessarily predicted. Their practices have changed, their lifestyles have changed. But as it relates to our day-to-day, obviously in the beginning of the pandemic, our clinics went completely virtual. We shut down all in-person work. And then slowly over time, that has come back to in-person mostly, though I will say that that certainly varies state to state and location to location. We've seen many patients who prefer to be managed remotely and not come into the office. And I think we are very privileged and lucky at this particular time in sleep medicine that we can do a lot of that work, right? We can manage them remotely with data downloads from CPAP machines and things like that. It has often been challenging to try and not lose patients, to make sure that the patients are actually following up as they should. I think that that is something that many people face. Keeping the labs in a good place has been difficult, and building protocols. Indira and her team, as this got all started, did an excellent job of relaying all sorts of information to us about how we might approach these things. So it has been a major change for us here. But I will say, even though the pandemic has been worsening and the data around the hospitalizations, et cetera, is not great right now, on the other hand, we are far better prepared at this point, a year later, I think, than we were at the beginning of all of this, to be able to manage our patients in an effective manner.
Great, thank you. Indira, I know the COVID-19 task force has been hard at work on some updates and just posted kind of an update on the Academy website now with some supplemental information, not necessarily changing any previous guidance or recommendations, but just adding to what's already been there with new evidence and new findings. And some of that has to do with healthcare worker safety. So we've learned a lot over the last year about how to keep healthcare workers safe in the hospitals and in the labs. And what is some of the information that we've learned over the past few months about that?
Thanks, Thomas. Well, first of all, I think that our field has done an amazing job of adapting to what's been required of us and has been very responsive to public health recommendations. So we're happy to say that the rates of transmission among healthcare workers has been low. There was a Mayo Clinic series that was published in a JAMA statement that said that in Mayo, at least 900 healthcare workers had COVID transmission, but 93% of them were from the community and not because of healthcare practices. 7% were happening, but usually in break rooms and cafeterias and so forth. So I think our strategies are working, and that's the number one thing to emphasize. And the second thing is keep doing what we're doing. And then as the vaccine rolls out, we offer in our newest guidance some suggestions that all of our membership should be aware of in terms of how do we go about with vaccine distribution and so forth, like staying connected to what the CDC is recommending, what state and local health departments are recommending, and what healthcare systems are offering. So, and Dr. Ramar is back, so I'll let him take it away.
So I was just going to touch upon some of the key AASM links for COVID-19 that you may want to be aware of. So if you have any questions related to COVID-19, please do use this email address, covid@aasm.org, as a way to get your questions answered. We have tons of resources for COVID-19, and they are within this particular web link out here. Similarly, we have a dedicated email for coding and reimbursement questions. We have actually Dr. Gray, one of our experts on coding, on on this particular webinar as well. So if you have any questions related, she'll be glad to answer that. And if not, definitely feel free to email her and the staff directly at coding@aasm.org. Similarly, we have tons of resources on telemedicine codes, and this is the link to take advantage of. And also we have Dr. Doug Kirsch, along with Deirdre, who will be happy to answer questions related to that as well too. Okay, so this is going to be the meat of the presentation. Quickly go through the COVID-19 Pulse survey results. As you all are very well aware, this is a second Pulse survey that we did, with the first one being in August of 2020, which I had the fortune to present that to you all in August. And this is a way for us to continue to gather the data in terms of the impact that the COVID-19 is creating for our members, and figuring out initiatives and strategies that we need to be doing at the board level, at the academy level, to help our members to move to overcome and remove any barriers related to COVID-19 moving forward. And the survey period for this second Pulse survey was between November 16th and December 2nd, 2020. So it was over a 2-week period. And email invitations were sent out to close to 10,000 members. And we had 500 or so members complete the survey, which gives us a response rate of about 5.2%, almost similar, if not close, to our previous response rate to the first Pulse survey. And this is typically the type of response rate we get for most of the surveys that we end up conducting. And the results are going to focus on the clinical demographics and 3 open-ended questions. So I'll start off with the results related to the clinical demographics, which included questions on clinical background, practice settings, and region. So I'll start off with the first one, looking at the clinical background. And here you can see that the total number of responses were 495. And most of them were from physicians, followed by director, manager, supervisors, sleep technologists, nurse practitioners, and you can see the remaining listed out here. The one point caveat that I wanted to put out here is that we added a new category this time around for the December survey, which was director, manager, supervisor category, which wasn't in existence in the previous survey results. And in fact, I'll share with you and so that we can try to compare what happened in August, and that's the results of August COVID-19 Pulse survey are highlighted on the light blue bar, while the dark blue bar represents the current December COVID-19 Pulse survey results. So as you can see, the physician response was a little bit lower in December. However, the category for director manager, which wasn't there in August, the response rate from this particular category was 32%. And not surprisingly, we see the other category of 15% drop down to 4.4 because we created this new category of director, manager, supervisor. Otherwise, you can see the other responses from our different members listed out here on this particular slide. So this is a question related to where people work, where the respondents work. And another caveat to keep in mind as you're looking through this results are that the respondents expressed more than one answer. So the data are presented as a percentage of responses and not as respondents. So here you can see 33% responded that they were from an academic hospital, 32% from non-academic hospital, and 29% from solo practices. And you can see the mixture with the other groups from VA and health maintenance organization. How does this compare to the the August 2018 survey results? So again, the light blue bar being the one from August, you can see that the solo practice clinical reps, it seems to be a little bit lower, while the other categories in terms of responses were similar. If you look at the practice location by region, most of our responses were from Southeast, followed by Great Lakes, Far West, Mid-East, and Southwest. And these regions are designated by the US Bureau of Economic Analysis. And if you look at the other category, these are our members from outside the US, which are our international members. So how does this compare to the August 2020 survey results? You can see here that our predominant responses were coming from, compared to August at least, more so from the Great Lakes area, followed by Far West and New England area. So this is a question related to what's happened from in terms of the number of patients people are seeing. You can see that the overall response is that 46% were seeing fewer patients, while 33% were seeing more patients, 20% saying no change. And again, when you compare this to what happened in August of 2020, you can see there's been a little, definitely a doubling of the number of patients being seen currently. However, let me just take a step back and talk about a couple of caveats here, because it's important to realize how we had asked this particular question. So in August, we asked a question in terms of change in patient volume in the last month. So basically looking at the month of June and July. In December, the question was specifically asking for change in patient volume since July of 2020. So while one does see here in this response, more patient percentage being doubled from August to December, it actually doesn't mean that their patient volume had returned to the pre-pandemic levels. It's just that they were seeing more patients in December, or I'm sorry, seeing more patients towards the end of the year than they were in July. So related to financial assistance, you can see that 46% did not seek financial assistance. Unfortunately, however, you still see 32% seeking financial assistance. And the question is, how does this compare to August of 2020? It almost looks similar, though a little bit lower percentage on the financial assistance category here in December compared to August of 2020. Again, another important caveat is that the results suggest that at least some of the respondents to each survey were different, because if they actually if we had the same respondents, then you would expect the numbers for the S category to be the same actually, or if not a little bit higher in December compared to August of 2020. So in terms of our members concerned from to remain financially solvent going into 2021, unfortunately, you can see the response is still pretty bad in terms of 44% saying that they are going to be okay, but 45% saying that they're going to have some issues remaining financially solvent. And in fact, if you compare this to August of 2020, it almost looks similar. Again, let me take a step back and touch upon a couple of caveats in terms of the type of question we had actually asked. In August, the question was specifically related to remaining financially solvent through the end of the year, while in December, the question was whether the facilities are going to be remaining financially solvent going into 2021. So though these numbers seem to be pretty close in terms of percentage-wise, the financial concerns continue to remain high among our sleep members, unfortunately. So if you look at the post-pandemic utilization of telemedicine, you can clearly see the use of telemedicine being greater than the pre-pandemic level, at least based on 67% responses. And the question is, how does this compare to August of 2020? And overall, you can see maybe a little bit slightly higher. And clearly, the December survey confirms that the sleep medicine professionals continue to anticipate that telemedicine is going to be playing a greater role in the field of sleep medicine moving forward. And another reason why we have Dr. Kirsch on this particular webinar to help answer or address any questions or concerns that you might have related to that. So in terms of employer travel restrictions, almost half of you said that you had travel restrictions, while the remaining half felt or did not have any travel restrictions. And so the question is, of course, these are just some of the sample comments from you all related to this particular question. And we specifically asked this particular question as a way to gauge our ability to figure out what is it that we need to be doing from education course perspective in 2021. Looking at the response from the survey and the comments, I think our decision in terms of moving APS's 2021 virtual, I think made a lot more sense now. And so I really appreciate you taking the time to respond to this and outlining your comments related to that. We are also hoping that that travel will open up sometime in summer, and this will then allow our members to attend the in-person sleep medicine trends and sleep medicine essential course in Austin, Texas, sometime in September. And this is our hope and anticipation. We'll see what happens as we move forward in the next few months. And hopefully with every one of us taking the vaccination, I think the hope might hopefully turn into reality. We'll see. So let's quickly go through the 3 open-ended questions that we asked our members. So the first one was related to 1 or 2 ways that COVID-19 was impacting your sleep practice or facility. And you can clearly see that majority felt that the impact was related to changes in practice, followed by patient volume decrease, and then also related to closures and reductions. Telehealth implementation, which I think was more on the positive side, that this had an impact on them. Dealing with fear, particularly among patients and some of the allied health providers. And you can see the other list out here. To clarify, when we say challenges in practice, this includes PPE cost, personal protective equipment cost, cleaning procedures, and associated costs. And when we talk about closures and reductions, this includes closures of the sleep labs, unfortunately, reduced testing, ceasing titration studies, and reduced hours as well. In terms of physician shortage and staff changes that's listed out here, this includes a reduction of staff, furloughs, new COVID-related hospital responsibilities. A new challenge that was mentioned in December that wasn't mentioned in August is related to rescheduling more patients who have tested positive for COVID. And this next slide touches upon comparing December with August 2020 survey results. And here you can see the changes in practice seem to be more in December compared to that on August. And I'll let you take a quick look at this slide in terms of how the results panned out between the 2 COVID-19 pulse survey results. And in fact, if you look at the sample comments here, people are still suffering. Here, this person indicated that he had to retire because his income plummeted by 80%. And you can see sleep labs closing, furloughs still happening. Patients testing positive, our state shut down elective procedures, and we had to close for approximately 6 weeks. The second open-ended question was related to what are the 1 to 2 strategies that we can, or the AASM could do to help you. 1 to 2 strategies that you as members are doing to help your facility adapt during this pandemic. And here you can see the predominant strategy that you took was implementing telehealth, followed by changes in operation, infection control protocols, expansion use of HITE-SAT and APAPs. And telehealth implementation included both phone and virtual options. The infection control protocols included screening questionnaires at the entrance, along with use of masks, PPE use, disposable HITE-SATs, and social distancing. In terms of changes in operation, this included, unfortunately, staff furloughs or layoffs, flexibility in hours, office closures, additional training, or no intake related to cases which were simple. And if you look at a new strategy that was mentioned in December that wasn't being done in August of 2020, it relates to the working from home policy for staff, along with patient education, hopefully addressing that fear aspect, and flexible cancellation policies. How does this compare to August of 2020? You can see this particular slide illustrating those points here, with the changes in operation being a little bit higher. The telehealth implementation, I think the number looked a little lower because one, it's either been implemented or some of those answers were captured in the previous open-ended question out there too. So these are some of the sample comments from our members related to the strategies that they are taking to help them overcome the pandemic. And I'll let you quickly read through some of them here. The last open-ended question was related to how can we at the AASM help you, our members, related to the pandemic, and help out the sleep practice and facilities. Most of you, 28% said advocacy efforts, followed by having AASM guidelines and periodic updates, which the COVID-19 task force is doing a fabulous job in getting those things out, and miscellaneous, which I'll touch upon here in a second. So advocacy included reimbursement, telemedicine reimbursement, including phone encounters. The member education that's mentioned out here by some included continuing education, podcasts, which as you can see is happening, along with webinars and networking opportunities. AASM funding and subsidies include free CME mock points, reduced dues and fees, and as you can clearly see on the second slide that I illustrated, some of these initiatives are already being done to help our members to overcome some of these financial hard constraints. Accreditation was seeking more flexibility, extended deadlines, virtual visits, and in fact, all of these are actually being implemented by our AASM accreditation department. The miscellaneous examples include embracing collaborative models with other practitioners, and also thanking the AASM staff for some of the initiatives that have been taken, including urging AASM to stop the panic that's unfortunately going on because that's affecting patient volumes and creating more fear, and to continue supporting labs. So this is how it compares to August of 2020. And overall, you can see that the request is still coming in for ongoing periodic updates, advocacy, and AASM guidelines. So these are some of the sample comments from our members related to that particular question. Continue issuing guidelines, recommendations, guidelines for sleep center sanitization in response to COVID, advocate for better reimbursement. And we are doing all of these, and hopefully more to come related to this in the next few months too. So I'll end up by touching upon a few updates here, and this is specifically related to COVID-19 task force, and Dr. Guru Bhagavatulla can elaborate a little bit more as during the panel discussion out here too. So there's going to be an updated guidance on the AASM website specifically addressing the vaccination aspect of patient communication, hopefully to address some of the issues that you all were raising in the COVID-19 Pulse survey. Scheduling care for COVID positive patients, how best to go about doing that, along with healthcare worker safety, which is another important aspect to keep in mind, particularly as the pandemic continues to go on here. Also, some of our COVID-19 task force members participated in webinars with the ATS in November and December, and also published an editorial specifically looking at pediatric sleep practices in this current pandemic. So if you haven't had a chance to look at it in terms of what to do from a pediatric sleep practice perspective, you may want to take a look at this particular link or this particular article on JCSM. We are also planning another Pulse survey sometime between March and April. We've been doing this every 3 months as a way to assess what's going on, basically to get a pulse of our members in terms of what's happening so that we can continue with these initiatives to help our members, our field, and our patients moving forward. Definitely make sure you send your questions related to COVID-19 to this covid@aasm.org email. And since we have Dr. Kirsch on the line as well, quick updates related to what he and his committee has been doing. They've created some fireside chat webcasts, and in fact, 2 parts have been done. The first part was getting started related to telemedicine and billing, privacy, and licensing. And so hopefully some of you had a chance to look at this. I think these are very well done and hopefully will be of some benefit for you. Coming soon are some of the things listed on this particular slide, including templates for comprehensive sleep evaluation for both adults and pediatrics, along with a template for obstructive sleep apnea follow-up for use in telemedicine. And then you're going to see some updated versions related to telemedicine position paper, along with implementation guide and some case studies to illustrate some examples that you might be able to use and apply in your practice. So these are other AASM priorities. The board has done an amazing job and will continue to take some initiatives and strategies to continue to help our members. And for that, I really do need to hear from you. And so feel free to send me an email at kramar@aasm.org. And as we hear from you, both on this particular webinar, as well as through email and questions that come through us, I think that's going to help guide our strategies and initiatives moving forward here. We're also going to be investing more in 2021 for lobbying and also for new public awareness campaigns. There's some of the questions and concerns that were raised by you all on the COVID-19 Pulse Survey hopefully will get addressed with these initiatives for this upcoming 2021 year. Looking at health policy and advocacy, we are recruiting more Congress folks for our new Congressional Sleep Health Caucus, which, as you might know, is up and running since October of 2020. And we'll continue to advocate for telemedicine reimbursement so that it becomes permanent, and also continue to advocate for relaxation of prior authorization policies. So we touched upon a few things that the Telemedicine Presidential Committee is doing, and they're continuing to develop other resources that might help you as members to benefit from as well too. The Payer Policy Review Committee is also looking at advocating for payer adoption of AASM recommended hypopnea scoring rules. And in fact, a few meetings have already happened related to this, and so more to come on that moving forward here too. So with that, my sincere apologies for that gap in my presentation at the start. With this, I think we'll open it up to the panel for further questions and discussions, and I'll stop sharing the screen and hand it back to you here, Thomas.
Thank you, Dr. Ramar, for this presentation. So let's go ahead and discuss some other questions related to the issues brought up by the survey. For this discussion, we'll welcome back our 2 panelists, Dr. Doug Kirsch, Chair of the Academy's Telemedicine Presidential Committee, and Dr. Indira Guru-Bagavatula, Chair of the COVID-19 Task Force. So welcome to you both. Dr. Guru-Bagavatula, I think we'll start with you. We do have a question in the Q&A feature in the webinar system about vaccination. Obviously, that's the hot topic kind of on everybody's mind right now. CDC is currently reporting over 12 million people in the US have received the first dose of the vaccine, so that's good progress. So, you know, where are we currently as far as vaccination and how that may or may not be changing clinical practice? And then looking forward as vaccination becomes more widespread, what do you think we have to look forward to?
Well, yes, absolutely. It's the hot topic. And first thing, as sleep healthcare practitioners, one of the key responsibilities for us is to encourage our own staff and patients to go ahead and get vaccinated, consistent with CDC guidance. And the CDC set up a tiered system of access so that those who are most vulnerable, either for contracting COVID and developing severe disease or at risk of spreading it to others, are at the top of the list. So healthcare workers and patients who live in extended living care facilities are at the top of the list. And then other essential workers, where most states now, I believe, are down at 1B, category 1B. Which includes frontline workers as well as community members who are 75 years or older. So this is information we need to be sharing with our patients and encouraging them to get vaccinated, answering their questions about what they can expect, what kind of side effects, what fears they have. There's a lot of misinformation out there, and we are often the only people they have access to who can give them accurate, scientifically based information that they can make their decisions on. So I think that as vaccine rolls out and uptake increases, what's expected would be the community prevalence rates hopefully will go down. It doesn't mean that patients who contract COVID-19, if they've been vaccinated, that they can no longer transmit to others. That was not shown. So we need to encourage our patients that even after vaccination, that they continue to follow the mitigation strategies. So wearing masks, keeping their distance, avoiding crowds, and so forth. And we'll continue to look for updated guidance from CDC and other health authorities, as far as what else we need to be doing. But our hope is that, the more people that are vaccinated, the burden of disease itself will eventually start to drop. And as far as our role in all of this as well, I think in the middle of all of this is the role of sleep in the immune response, right? And this is another important take-home message for our patients. And we have a web page that we shared with our membership that talks about sleep's role in immunity. We don't have direct data for this particular vaccine, but based on best available evidence for prior vaccines, including flu and Hep A and Hep B, we know that good sleep helps modulate the immune response so that you get a more robust response, and your chance of responding the way you should with the vaccine will be optimized. So we need to tell our patients, come for your visits, get your sleep needs met, get your sleep apnea screened, get it addressed. If you have insomnia, have it handled. It's a really important time right now. It's a fundamental pillar of good health and an important component of a robust immune response. So that's what I have to say about that.
Just to add on to that, Indra, I think that's a great, wonderful points brought up. I think the Sleep Insider this past weekend touched upon that sleep and immunity aspect, and including a couple of comments related to that might be of help to our members as they not only use it for themselves, but also apply it or pass it on to their patients too, so that way you can use that as a way to reinforce the importance of sleep, particularly as they're getting vaccinated, to boost their immune response to this.
Yeah, and I would add also, in my practice at least, the people I'm seeing that are hurting in many ways are our older patients, and the ones that were already in for this pandemic has really put a highlight on all the disparities that already existed in our systems. The people with cognitive and physical impairments, elderly people, those who are socioeconomically deprived, that don't have access to Wi-Fi or smartphones. And those are the ones that are also at greatest risk for severe disease if they get COVID-19. So those are the people we really need to advocate for in terms of vaccine distribution and access, so that we can then make it safe for them to travel and come in person again and continue to get the care they need.
And Indira, just one follow-up question to that. As far as clinical practice, as sleep center staff begin to get vaccinated, at the current level, is it too soon to even think about changing mitigation strategies as far as pre-screening patients and use of PPE and all the other things that labs are currently doing?
Yeah, it's a little early, and we will be on top of that and offer updated guidance once we know more. But right now it is hold the fort, keep doing what you're doing. One thing I would advise sleep labs and sleep practices to do, what we discussed as a committee, is that stagger the schedule so that all your techs aren't going out on the same day and all of them aren't going for the second vaccine on the same day. As far as side effects, it's a spectrum, and some people have barely any reaction at all, and other people feel kind of tired and they want to rest the next day. And we seem to be seeing a little bit more side effects with the second shot as opposed to the first. So you want to make sure you have a backup call schedule in case someone needs to take a sick day. So stagger your responses, have your staff be prepared, and adjust their work responsibilities and their personal responsibilities accordingly. Yeah, and the other thing is taking Tylenol and Motrin, things like that ahead of time. Right now, it's advised that you not do that, because you don't want to blunt. We don't, again, have direct evidence for this particular vaccine. That data comes from pediatric data with other vaccines. We don't want to blunt your body's ability to mount immunity to this. So don't pre-medicate. If you have severe symptoms afterwards, after the fact, and you really need to take something that, like Tylenol, then that's something that can be reconsidered. But try to take the shot as given.
Dr. Kirsch, both of the two poll surveys we've done so far, we've seen about 2/3 of respondents expecting telemedicine to continue to play a big role in sleep medicine even after the pandemic resolves. What are your thoughts about that? Is that a good thing that you think is going to take place for the sleep field?
I think a lot of what will happen with telemedicine will depend on reimbursement, but I think my hope is that it continues to be a big piece of what we do. I think assuming adequate reimbursement for the clinic visits that we do in that way, it's an effective way of reaching places that we might not reach, of finding patients that we might not otherwise get. And I was trying to scan through the chat briefly as the other speakers were talking, and there's a comment about rural access. And I will say, certainly in the area in which I practice in North Carolina, we are reaching out to patients well beyond our usual radius of seeing patients, saving them hours of driving to come see us for 20 minutes. And I think that that's an amazing savings for that patient's time, and allows them most of what needs to occur in a relatively time-shortened visit. So I think telemedicine has the ability for us to be into access, not just within our region, if you're in a city and reaching those patients who you might not want to get out in the midst of the pandemic, as Indira was sort of referring to, but also to patients well beyond our usual radius. And I think given what we know around the fact that sleep clinicians tend to be in metro areas, they tend not to be as dense in some of the rural areas, and the fact that we know that many people in rural areas need sleep care, this may be a way for us to expand the reach of the sleep physician and the sleep team well beyond where we're getting today. And I think that that's fantastic. And I think the fact that even though vaccines on the way and things are, I think, hopefully pointing in a positive direction, things aren't going to go right snap back to normal. And I think we can expect to see impacts to our practices over the next 9 months to year would be my guess. And that being said, telemedicine will help keep us practicing in that time frame.
Add on to that too, Doug, I think from a patient-centric care perspective, having some options available, both whether they would want in the future, even post-pandemic, whether they want it as a option to be an in-person meeting versus to do it via tele would be a good one for them to have. But that goes back to the point that you rightly brought up at the beginning, which is reimbursement. And I think that's where the Academy, along with the other societies, have been strongly advocating from that perspective to make this permanent.
And Dr. Kirsch, one follow-up there is that there are two sides to the telemedicine coin that we see in our survey results, right? So it's one of the new strategies a lot of facilities have implemented this year in response to the pandemic. Then we also see it reported in the challenges area where facilities are having some challenges there as well. And I know that's something that your committee has been working hard to address. Can you tell us a little bit about some of the resources that your committee is developing to help address some of those challenges?
Absolutely. I mean, I think the first thing to say is telemedicine came much more rapidly for some than anticipated, right? So in January of last year, a very small number of people were using telemedicine. Suddenly in April, a lot more people were using telemedicine than had been previously, and without a lot of training or a lot of resource ability to do so. And so many people adapted in that short time frame, but as the committee got started in May, June of last year, part of what my committee's responsibilities were is to make sure that we updated guidance around telemedicine implementation to try and bring information to people who are practicing. And obviously with committee work, it always takes longer than you anticipate, but our hope was to get those webinars out sooner rather than later. It takes longer, again, than you always hope it will, but hopefully you'll find those webinars that were put together by our committee really valuable, really talking about the different challenges and practices that have sort of jumped up as we've all kind of learned some of the tricks of the trade, so to speak. And then the templates. So the templates were originally developed because in 2020 E&M coding, there needed to be hopefully some guidance around some of the things that might be useful to have in a standard intake for sleep medicine. And we developed it for sort of a typical adult, and then are currently in progress on typical child, as well as in a sleep apnea follow-up, which is probably the most common. And we recognize that the template isn't something that everybody will use. We recognize that it's not something that everybody's going to find useful, but the hope is to provide some level of standardization that says, hey, if you're picking this up for the first time, or you built something on the fly, but you're not sure it's as good as it could be, the idea is that these templates will exist to kind of help guide you and sort of give you some of the questions to ask and some of the things you can do on the exam via telemedicine, with the then hope that, over time, these templates, which are currently going to be PDF forms, could be integrated into EMRs and things like that to really make the process somewhat easier. And so that's kind of been the three-part approach, kind of updating the paperwork, webinars and information spread, and then building templates through the Telemedicine Presidential Committee.
Great, thank you. We do have our Director of Health Policy, Deidre Gray, on the line. It's going to come to her with a couple coding and reimbursement questions in just a moment. But Indira, I have one more question for you. So the COVID-19 Task Force does have a new update that's available on the website today, covering a variety of topics, including vaccination, patient communication, healthcare worker safety. There's also this question of scheduling care for patients who have tested positive for COVID. We've received a number of questions from members dealing with that issue. What are the CDC recommendations for ending isolation for a patient who has tested positive? And I guess we could say there's kind of a 10-20 rule that CDC has there. Can you tell us a little bit more about that?
Yeah, so the CDC in the beginning was using a test-based strategy, so people had to test negative before they were considered cleared, and they moved away from that to a symptom-based strategy. So really, how long they should stay out of your sleep lab has to do with how bad was their infection. So if it was on the milder side, then, or if they were completely asymptomatic, or then 10 days from either their positive test or when their symptoms started. But if they were more severely ill, then a minimum of 20 days before you bring them into your lab. And then if 90 days or more have passed since they got sick, then you want to go back to testing again, because they might have been reinfected and their immunity may have waned in the interim. So so we do recommend, but if someone just recovered and they're clearly recovered and they're feeling better, then they're not advocating retesting them again. The other group to be aware of are the people who have chronic immunosuppressive illnesses, patients who are cancer patients on chemotherapy. They can have persistent positive tests for a long time that don't necessarily mean that they're infectious. They may have had remnants of infection and fragments of RNA that are showing up on their PCR test, but it doesn't mean that they're necessarily going to transmit illness. So again, for those people, like rather than testing them again and again, like use the symptom-based strategy. And this is the CDC recommendation. And we have that up on the website as well.
Great, thank you. I'd like to go to Deidre. Deidre, are you there for a couple of coding reimbursement questions?
Yeah, I'm here.
Great. So we did have kind of a bad news, good news scenario play out last month, where the physician fee schedule came out. And due to budget neutrality requirements, there were some pretty bleak numbers in there for the 2021 physician fee schedule. And then Congress kind of came through at the last minute with some legislation that helped avert some of those cuts. Can you briefly tell us a little bit about that?
Absolutely. So initially, when the physician fee schedule final rule was published on December 1st, the document stated that CMS was going to move forward with finalizing the really low conversion factor, which would have reduced reimbursements by, I think, 10 to 11% across the board for all specialties. That was finalized, however, and we did release a full analysis of the physician fee schedule at that time. However, on December 28th or 29th, like you said, there was a revision that was published, which was seemingly great news, which actually allowed CMS to increase the conversion factor by 7.6%. And so hopefully, members have been able to see an explanation for that in this past weekend Sleep Medicine Weekly Insider. We usually develop some payment and RVU documents in order to summarize the reimbursements for the year based on the final rule. So we had originally released some, but over this past weekend, we released some updated versions. So you'll be able to see the significant differences in what was originally finalized and what is actually going to be reimbursed. And so I think that is a great relief to many people.
Great, thank you. Well, one of the specific questions that's on really everybody's mind is in terms of telemedicine reimbursement. Going into 2021 now, can you tell us kind of what things currently look like for telemedicine reimbursement and where that may head in the future?
Yes, absolutely. So CMS, through its rulemaking process, which I briefly just alluded to, has been sort of updating us on what they plan to do in the long term. It's kind of a crawl before you walk situation. So originally, when the public health emergency started, CMS had published 2 different interim final rules, and one was at the end of March and one was at the end of April. That's where they originally started to expand all of the telemedicine allowances and really allow people to forego in-person visits. At this point in the final rule, they've started to finalize some policies that will extend beyond the public health emergency. Some of those are telemedicine related, some of them are not. But we're seeing that they're trying to, based on the advocacy, they're trying to, in the event that they cannot finalize telemedicine reimbursements based on the existing CPT code set, they're creating G codes in some of those instances to allow people to continue to be able to reimburse beyond the public health emergency. So one example of that is the G2252 code. That is something that was recently created on an interim basis to address all the concern that was in people's responses to the proposed rule about no longer being able to reimburse audio-only visits. We know that a lot of patients either don't have smartphones, don't know how to use smartphones, particularly on the elderly population. It's been a little tricky. And so given all of the advocacy, and we were one of the organizations that strongly advocated for them to finalize keep all of the telemedicine reimbursement going. But that was one that they received a lot of comments about. I think they received over 40,000 comments on the proposed rule, by the way. And so that's one way they are attempting to address it. There is again, an analysis of the final rule available on the website. And you can also access our response letter to the proposed rule to get a sense of what we've been advocating for. And then always feel free to send any coding or reimbursement questions, whether related to telemedicine or otherwise, to coding@aasm.org, and we'll get back to you and try and help as much as we can.
And Deidre, the other thing that's helped us a lot is the relaxation of cross-border reciprocity with licensure. Mm-hmm. It's really helped, our interstate patients stay at home and continue to access their usual doctor. So I hope that also continues moving forward.
Yeah, CMS did address that in the final rule as well. What they were saying in the proposed rule is that they can't make an adjustment to that rule. It has to be something that's advocated for through legislation, and there has to be some change that way. In the final rule, they did say that there have been some changes to it so far. So I feel like whatever advocacy is going on the Hill is working. And then, like I said, the comments that are being submitted, and there's been a lot of pain points that people have been emphasizing in their letters to CMS to just sort of urge them to keep that going. I think what they're going to end up finalizing is to continue the allowance for rural situations for people in rural communities to be able to continue using telehealth. But there's just still some gray area because we don't know how the law will continue to change. So we'll obviously keep everyone updated on that. And one additional thing I did want to mention that no one asked, but the CPT code 99072 was finalized on an interim basis. So every time you see a patient and you bill an E&M code, you can bill 99072 along with that. So I encourage everyone, that's the code that reimburses for the use of PPE, additional costs related to modifying your practice, cleaning supplies, all of those indirect and direct costs. I encourage everyone to add that 99072 code so that you can collect more reimbursement.
Thank you, Deidre. Dr. Kirsch, so the future of telemedicine and reimbursement is not crystal clear, but as one of our attendees pointed out in the Q&A section, they have to make decisions now about how they're going to invest for telemedicine going forward. Any advice or words of wisdom you have for sleep facilities who are making those decisions now?
I mean, I find it difficult to believe that telemedicine is really going to be shoved back into the sort of minimal box that it was in before. I think that, this year has shown the power of telemedicine and the positives that it can do. I think these days the cost of entry is not so high. I mean, I think depending on what you're talking about investing in, I mean, I think it's not nearly as high as it once was, but there are easier and more expensive ways of getting into telemedicine depending on the situation. Some of it may just be that you do some of the stuff temporarily. Yes, you need equipment, you need a webcam, you need a computer with a screen. But in terms of services and things like that, it's not ultra expensive, and some of them are even, relatively speaking, free, right? So I don't think the investment has to be heavy until it becomes more clear what's going to happen. On the other hand, I suspect at least over the next year, and then probably beyond that, we'd be looking at some amount of telemedicine going on in everybody's practice. How much? Hard to know, but not zero would be my guess.
I think also moving forward, we'll start to see more guidance around safe telemedicine practices. I don't know about you, but at the beginning of the pandemic, my patients were home, planted on their couch, ready to go. And my show rates were extremely high. And then as the pandemic went on and people are starting to drive and do all kinds of things when they really shouldn't be doing those things while they're on a video conference call. So that's been challenging. And the other piece of this is education. How do we educate our fellows and ensure three-way calling and that they have adequate training with physical exam and history taking and all of that without this direct hands-on approach we've always had. So I think we'll start to see all of that get more refined as we keep going.
Right. I mean, I will say, I think we had to add something about people being in a safe situation into the templates, which you would think would be relatively straightforward. But yes, I've had people trying to drive their car and talk to me at the same time about their medical care, which didn't seem ideal. And we had a conversation about that, and distracted driving as opposed to sleepy driving, which we usually talk about. But I will also say that, this the thought that visits in person and visits via telemedicine are exactly the same, obviously not. There is a learning curve. And I think one of the challenges is really around the exam, more so than perhaps anything else, right? The questions we ask are the questions we ask. But I was conversing with somebody recently about, how good is this patient as a dental device candidate? And I think that can be difficult to tell on an oral exam done via a smartphone. And so while the visits are fairly similar, and for instance, a CPAP follow-up, it may be very similar for someone who's doing well, but for someone who's not doing well, you might fit him with a mask in the office, or someone you're trying to determine an alternative non-CPAP treatment, it still is a challenge in telemedicine. I think that this is the steps and challenges we're going to try and have our webinar folks discuss over the next several webinars that they release.
Yeah, so Doug, the other thing we don't necessarily talk about when we think about telemedicine, our practices are heavily focused on outpatient care, but telemedicine can expand access to inpatient care, right? So you can actually start to see patients while they're hospitalized, they're captive, they're right there, and they're receptive to, for asthma, for example, if we start them on their inhalers when they're, admitted after a severe exacerbation, there's data that they're actually more likely to be adherent to your recommendations. So in a field that struggles with adherence issues, maybe capturing that inpatient audience and leveraging telemedicine technologies to cover some of these visits. And the nice thing is you can get objective data, far more objective data in an inpatient setting than you would in a patient's home to help with decision making. So
that's the other side of the coin. Also from a patient perspective, there's been not necessarily from AASM, but there's data from other survey that indicates that patients prefer, more patients actually prefer the telemedicine approach. And interestingly, 65 years and above, where you thought that might be the group that may not want the telemedicine just because of the complexities of using these devices, actually we're embracing that as well. The only reason I throw that out is because going back to the question that was posed, what's going to happen in the future and do we need to invest in it? I think if the patients are bought into this concept and there's a strong advocacy effort that's also coming from the patient's perspective, apart from advocacy on our side, from a provider's perspective, I think both are going to help significantly to move the needle towards making this a little bit more permanent. And Thomas, who's on this call too, we are looking at, since this is more of a non-sleep data that's been looking at it from a patient's perspective, I think it's important also to collect information on sleep patients and see what are they thinking about this, where do we see the field from their perspective. I think it's going to be important as well. So I think we're going to look at doing a survey related to that as well in the near future. And hopefully once we get some more information from that, we should be sharing that with our members here too.
Yeah, I think other areas of expansion are in terms of coverage are services that maximize efficiency of our sleep center staff. So group visits, for example, right? So when there's repetitive education and they allow this advantage of peer-to-peer mentoring and peer-to-peer counseling. So I think that's another place we can look moving forward.
Group visits is hard in a pandemic currently, but yes, I will say we used that a fair bit prior to the pandemic.
No, I mean with telemedicine, Doug, where everybody logs in for an educational set, just like we're doing now.
Yep, you could do it that way as well. It just depends on what you're trying to educate on. If it's CPAP, obviously one thing, right? I mean, it depends on what you're trying to discuss and how you might leverage that. But yes, I agree.
Yeah. So we've had group CPAP setups. So, if people are, set up on CPAP and have a question answer session, something along this line, but if we could offer reimbursement for this type of activity, it would be a very efficient way to educate lots of people at once. There are HIPAA and other things to think about and a whole other can of worms, but we got to start thinking outside of the box, I guess.
Dr. Ramar, we've passed the top of the hour, so I'm going to bring it back to you for some closing thoughts. You've been posting some monthly messages on the Academy website throughout the last few months, and words you continue to come back to in those messages are words like courage and optimism, teamwork, resilience, and adaptability. Tell us just a little bit more about what's been on your mind throughout this as you've watched the sleep field respond to this. You've seen our members respond. What thoughts have come to your mind?
Yeah, that's a great question. And I think I'm going to say maybe three things here, Thomas. So one is thank you. Second is grit and resilience. And third is hope. First of all, since we're going to be wrapping up here, let me start off by thanking both Dr. Gurubhagavathila and Dr. Kirsch for taking their time away from their practice to be on this as expert panelists. And again, thank you, Doug. Thank you, Indra, for a wonderful job that you did in terms of helping answer some of these questions to help our members, our field, and hopefully our patients as well moving forward here. So really appreciate you being on this webinar. Second, a huge thanks to Thomas, you as a moderator, along with Kathleen, Mike, Lizzie, Deirdre, who did a fabulous job answering some of these tough code questions, which I'm so glad she's on to take care of those. Again, kudos to you and of course, Steve Van Hout, our Executive Director, along with our AASM staff for the amount of work that they've done behind the scenes to implement many of these initiatives has been humongous. And so I really want to thank them, despite this pandemic and despite working from home, getting these things accomplished to help our members. I want to extend a special thanks to them. And of course, none of these things would be happening without my colleagues and friends on the board. And a special thanks to the board members for helping our members and the Academy in terms of coming up with new strategies, thinking out of the box, and putting forth these initiatives to help us moving forward. And most importantly, I think this is where it goes back to the question that you were asking, Thomas. A big thank you to our members. I think you've gone through a lot this past year. And definitely the COVID-19 Pulse survey, both the previous one and this one, clearly illustrates the hardships that you're all going through, both from a financial, social point of view. And I think this is really where I want to thank you for being able to not only take care of it, but also take care of your loved ones, your family, and the patients. And in terms, and through that means benefiting the field. I've learned a lot from you all, so I really appreciate you doing that. And I think this is where clearly your grit and resilience comes to the fore. The fact that you've been able to put up with all these things and still show the strength and courage to be able to overcome these difficulties moving forward it's been exemplary. And that leads on to the next part, which is the hope, because really this brings hope that we're going to have a better future moving forward. And I think I've said this before, together we can do anything. And this again brings to me the fact that we can together, and hopefully 2021 would be a better future for all of us moving forward. And well, let's continue to hope for a better future, and together we can in the meantime surmount and take care of these barriers and difficulties. And with that, I'll thank you all for joining, and have a wonderful day, and we'll hopefully see you all in person sometime soon here.
Well, I thank Dr. Ramar, Dr. Kirsch, and Dr. Gurugapatula for this timely presentation and discussion. As a reminder, the recording of this webinar will be made available as a free resource on the Academy website at aasm.org. If you have questions about this webinar or the topic of COVID-19, please reach out to us at covid@aasm.org, or for coding questions, contact us at coding@aasm.org. This concludes the Presidential Town Hall Forum presented by the American Academy of Sleep Medicine. Thank you for joining us.